Thanks, Tian. Welcome everyone to day 2 of the Carer Knowledge Exchange Research Incubator for 2023. Today's title, Making Connections, Exploring Carer Health and Wellbeing. Before I begin, can I just note that this session is being recorded, and if anybody has an issue with that, could they let us know in the chat? My name is Professor Karen Wills. I'm the Director of the Institute for Public Policy and Governance at UTS, and we are one of the partners in the Knowledge Exchange with Carers New South Wales. Carers is an organisation with which I've had a long connection, both as part of my role at UTS, but previously. And, this has been one of the perhaps more rewarding parts of our program in the last couple of years, to really build a way of uniting the work between researchers, practitioners, people who are carers, people who are advocating on behalf of carers, etc. And the growth of interest in this program and the level of, I suppose, commitment to people to it is incredibly rewarding, and I appreciate all of the effort that my team, Carers New South Wales team, and everyone who you'll be speaking with today and participating today have put in. I'd like to begin the session by acknowledging country. I am coming to you today from the Gadigal people's land of the Eora Nation, and I'd also like to extend my respects to the lands on which all of our panellists and participants are joining us from today. I acknowledge elders past, present and emerging, and extend respect to all Aboriginal people, including Aboriginal people joining us today. Thank you. Just a little bit of an overview of the session. Some of you will be pretty familiar with this, but just to make sure that we're all clear what we're going to be doing today. This year's Research Incubator is delivered over 3 days, hosted by, as I've said, both Carers New South Wales and the Institute of Public Policy, for which I'm the Director. Our opening session yesterday explored evidence-based carer health and wellbeing initiatives. Today's session will delve deeper into how service access, social connectedness and diversity can impact health and wellbeing. Our first session will discuss service literacy and service access, followed by 2 concurrent sessions, one focusing on connectedness and wellbeing, and the other on hidden carers and carer diversity. The Research Incubator will close tomorrow afternoon with an online workshop focused on measuring carer wellbeing in research and in practice. In line with the aims of the Carers Exchange, this year's incubator brings together researchers, policymakers, practitioners, and carers to share their knowledge and learn from one another. This program was designed to help improve wealth and wellbeing outcomes for carers right across Australia by connecting research to practice. Our first session is in a panel format, hosted by Karen Martin, a member of the Carer Knowledge Exchange Advisory Group. We will hear from 3 panellists, followed by a facilitated Q&A led by Karen, where we will be taking questions from the audience. So if you have questions for speakers as they're presenting, please type these into the Q&A function, and we will return to these later in the session. Now I'd like to hand over to Karen for the first part of today's program.
Thank you, Carol. Hopefully my background is up there. Yeah, so as you can see from my background, there's a bit of a hint. I'm coming to you from Wiradjuri country in the beautiful central west of New South Wales. I've been a carer for my sister, my parents as they've aged, and now my adult son for nearly 40 years. And in that time, I've experienced many changes in how services are delivered in the disability and ageing spaces, and I've even worked in those spaces. From my own experiences, I've struggled to access different services at different times. And this is despite all the best practice guidelines that are out there and the never-ending rhetoric around person-centred approaches. In fact, I get quite frustrated with the whole person-centred approach because it's often misunderstood or misapplied, and sometimes it's used to block innovation, and providers who are very overwhelmed struggle to provide person-centred care in a way that individuals actually need and want. You know, as carers, we're expected to also understand how all the support systems work and the legislative instruments that underpin them frame support services, and then use that knowledge to determine what services and when and how often we require them. But none of us come to the role of a carer pre-programmed with any of this information. And essentially we start from a base of we don't know what we don't know. And as a carer, I've had to learn about how to be a carer, how to be literate, service literate, and how to access services. and navigate service systems and work out what's actually available to us. Most of what I have learned has been from other carers, and that's been through incidental conversations in car parks, after therapy sessions, or during casual chats in support groups, or while sitting in a specialist waiting room. And I would really encourage everybody here amongst the carers, if you haven't done so yet, join a Carers New South Wales support group or take advantage of some of the care education that they offer, because these are the places where carers can hear the practical information that can absolutely change lives. Yesterday, as mentioned, we heard from speakers who spoke of the need for connection, and connection is so important for carers, to connect with one another and to use our communal knowledge to build our own service literacy. And this is why I'm so supportive of the Carers Knowledge Exchange. It's a place where carers can explore their options, arm themselves with peer-reviewed evidence, and use that information to strengthen their discussions with service providers, as well as funding agencies such as My Aged Care and the NDIS. Pardon me. Today's session is about service literacy and access, and there are many studies that support the notion that better service literacy leads to better outcomes. But, what does that actually mean? As a carer, what does that mean? Well, for me, it means devouring information, speaking with other carers and service providers, and trying to work out how these systems work. And then take that information and work with service providers and others who work with us within those frameworks to achieve our goals. So by understanding what's available and how it's delivered, helps us work out how we can actually achieve those goals. As a carer, both within the NDIS and My Aged Care systems, I've had to wage many battles, some of them quite exhausting, and some that have been interspersed with disappointments, tears and bewilderments at how it all can be so hard at times. And in my own situation, it's taken a lot of no's before I finally got a yes that unlocked the potential of my son, who I now proudly tell people went from having very low expectations of what he would achieve to now working in open employment as a valued member in a top-tier Sydney law firm. It wasn't easy, but when it all comes together as it should, it's amazing. And our best hope to achieve amazing is to take every opportunity to learn and to listen to others walking similar paths, and then use that information to craft our own amazing. I could go on, and some of the people here assembled know that I can go on for ages about this, but we do have three wonderful panellists who are going to do a much better job than I could and speak to us on the barriers and some of the measures to support carers, service literacy development and service access knowledge. And they'll showcase some lived experience, some practice, policy and research perspectives. And remember, if you've got any questions along the way for our speakers, please use the Q&A function so that we can return to these at the end of this session. So without much further ado, I'd like to introduce our very first speaker, Dr. Rosalie Power. Dr. Power is an Associate Research Fellow with the Translational Health Research Institute at Western Sydney University. And Rosalie's research focuses on health and wellbeing in the context of marginalisation, including for children and young people with disability, the LGBTQI communities, and new migrant and refugee communities. Rooted in disability justice, Rosalie's research is driven by an interest to understand and reduce inequalities with an emancipatory research paradigm. And yes, I had to practice that a few times. Today she'll be speaking about the impacts of healthcare professionals' attitudes and knowledge of practice service literacy and service access of LGBTQI patients living with cancer and their carers. So over to you. Thank you.
Thanks, Karen. And I feel like I would have been quite happy for you to keep talking. It was really interesting to hear your background and what your introduction to the session. So today I'll be talking about, my name's Rosalie. I'm an Associate Research Fellow at Western Sydney University, and today I'm going to present to you about a research project I've been involved with for the past 4 years called Out With Cancer. And this research project has examined LGBTQI+ people's experiences of cancer survivorship and care. It's an ARC linkage funded project, which means we've got heaps of partner organisations, including Prostate Cancer Foundation Australia, Cancer Council New South Wales, Canteen, ACON, LGBTQI Health Australia, and Breast Cancer Network Australia. And we had investigators from different institutions nationally. So it was a really big study. What we wanted to do was really understand what's going on for people and how cancer support can be better tailored to meet people's needs. I'm sure most people are familiar with the LGBTQI acronym, but just in case, it means lesbian, gay, bisexual, transgender, queer, and intersex. So we're basically talking about anybody who's same-sex attracted or gender diverse or has an intersex variation. I'm often asked in this area of research, why are LGBTQI patients and their carers an important group in cancer care? Isn't cancer the same, cancer or caregiving the same for everybody? And why would LGBTQI people be any different? Well, firstly, LGBTQI people with cancer are a substantive population with over 20,000 new cancer diagnoses predicted annually. So we're considered a growing and medically underserved population in cancer care, and we represent an ignored epidemic. There's also growing acknowledgement that LGBTQI people with cancer have unique psychosocial vulnerabilities and health disparities that differentiate them from non-LGBTQI+ people with cancer. We've got higher rates of some cancer, so anal, breast, gynecological, and lung cancer in particular. And this is partly explained by things like higher rates of smoking and alcohol consumption and lower rates of cancer screening, among other factors. LGBTQI+ communities also report difficulties accessing cancer services, and some of our communities report higher levels of distress and lower quality of life. So LGBTQI+ cancer survivorship is an issue that is on the mainstream agenda, but until recently, there's been very little research or targeted information for patients and carers and to inform cancer services. And so that led to the Out With Cancer study. It's the first study internationally to look across different identities and cancer types and explore experiences from the perspective of not only people with cancer themselves, but also their partners and other carers and healthcare professionals. To do this, we used surveys, interviews, and photo elicitation. So that's interviews using photos to guide the interview content. And through this, we were able to explore various aspects of LGBTQI cancer and cancer care. And as I go on, some of the photos on my slides are actually provided by participants, so you can visually see some of the experiences people have had. We used a knowledge translation framework, which meant that we've worked really closely with those partner organisations that I mentioned to put the research findings into practice, to develop resources, information, and to change practices so that cancer care is more culturally safe and inclusive. You've probably got a sense by now that there's so many aspects to the study. So for the purpose of today, I'm really going to focus in on LGBTQI+ cancer carer experiences. And unfortunately, I couldn't have a carer with me presenting today. So I'm going to try and use the language of our participants as much as possible. I've included quotes on just about every slide from here. So hopefully you'll get a sense of people's voices. We've published a couple of papers that have included some data from carers, but our main paper is yet to come out. And so this is sort of the first presentation of some of this information. So you're getting an early bird preview of some of what we found. We heard from 132 LGBTQI cancer carers. Most people were based in Australia, but we also had people internationally, mostly from Western countries, the USA, UK, New Zealand, and Canada. Most people were female, but we had a range of gender identities, including 23 transgender people, so including trans men, trans women, and people who are non-binary. And most people were lesbian, gay, or homosexual. But again, our communities are really diverse and broad, and we had people with a whole range of sexuality identity descriptors that they used. And we had a small group of people with intersex variations. Most carers were caring for their partner or former partner who had cancer. And most of those people had breast or ovarian cancer. But again, you can see there's a huge array of cancer types that are represented. So we had really diverse demographics in terms of who we were hearing from and what their issues and needs were in cancer care. What we found out from people is that 42% of LGBTQI+ carers had high or very high distress. This was actually really similar levels of distress as to the people with cancer in our study. So I think that's quite an interesting finding. And we found that people who were bisexual and adolescents and young adults actually had the highest rates of distress. Distress was associated with experiences of discrimination in cancer care, in cancer caring, if caring had impacted health or had a financial impact, and if carers lacked family support. So I'll speak to some of these now. Participants also told us that there's distress was impacted by having to push their sexuality and gender identities to the sidelines whilst being a carer. Mostly we heard this from adolescents and young adult carers, but we heard it actually also across the board. So Cody told us that a 38-year-old non-binary queer person who was caring for their grandmother with terminal bowel cancer told us that they actually stopped taking hormones and presented as more feminine while they were caring. One, because they didn't want being non-binary to affect the care that their grandmother received. If healthcare professionals were prejudiced or discriminatory, they were worried that could get in the way. And second, it was just logistically really difficult. They needed to go to the city to get their medication, and that just wasn't easy to juggle with needing to also be present in the hospital for their grandmother. Some people also struggled with if to share their sexuality or gender identity, particularly if they were caring for someone with terminal cancer. So Zara was concerned that if she came out as queer, that her mum would lose friends and that their support network would be affected. And this other survey participant that I've got quoted here said they actually never came out to their dad as they didn't want to put extra stress on him in their final months. Participants were concerned sometimes that if they came out and that fractured the relationship with the person that they were caring from, they might not be able to fix it before the person they were caring for died. So there was some really difficult decision-making that people had to do about balancing their identity, working out who they are, what they want to share, but also being authentic in their relationship, a really complicated dynamic. 1 in 5 carers had experienced discrimination as part of cancer caring, so within the medical system. To me, that's shockingly high. And discrimination took many forms. I won't go into all of that, as some of those stories can be distressing, but there's 2 that I really wanted to mention. One woman told us that when visiting her wife in hospital, I think they'd been together for 13 or more years, her son was allowed into the ward, but she was actually made to wait outside because the nurse said that she's not family. And so she was made to wait in the hallway while her son went in and visited his mum and her wife. Another man told us that his partner's medical team were making a decision about turning off his life support and that he was excluded from that decision-making. He was told he needed to leave the room, again, because he wasn't seen as family. And so he needed to bring in legal support at such a traumatic and vulnerable and sacred time in order to be seen for the role that he held. Even if participants hadn't experienced discrimination directly, they certainly feared it. In our communities, people have come from long histories of prejudice and discrimination, pathologization and criminalization, and that's carried with us. So whether we've experienced it or not, people also often know stories of somebody that something's happened to, so it can be quite close to home. A 72-year-old gay man caring for his husband with prostate cancer told us that the staff kept, the healthcare professionals kept referring to him as his partner's friend rather than his husband, even though he'd made that clear. And Faye, similar to the story I just told you before, was really concerned that she might be excluded from medical decision-making. So to counter this, she sought legal protection, such as becoming appointed a power of attorney. Other people got married, which has been possible more recently, but for a long time that hasn't been possible. And so those sort of legal protections have offered people more authority in medical settings, but there's still an anxiety that that's going to happen to you. Some carers reported rejection and exclusion from their partner's family who wouldn't recognise their role as a carer, also really distressing. So Lucinda, who'd been with her partner for 11 years, her partner actually wasn't out to her family because her family was very religious. So when she got sick, her family came to take care of her, but didn't know the dynamic of their relationship and basically told Lucinda, well, she quotes them as saying, off you go, we've got this now, piss off. So that was pretty tough. And she said that when her partner died, she wasn't acknowledged or mentioned at all. And so that was really traumatic. It was like she'd been wiped. Those 11 years had never existed. Carers also told us that they lacked support or had difficulty accessing support. Leslie said that being queer made her experience as a carer more traumatic, and that when attending support groups, she couldn't relate to the other people there. It often meant walking into a room of men who were 20 years older than her, and she couldn't really identify with the problems that they were experiencing. Others said that they just couldn't seek support because that would mean coming out, and they just couldn't risk that. And for many people, the LGBTQI+ community is a really great sense of support. And whilst that was certainly the case for some, others felt unable to access support here. So this 38-year-old queer femme carer who was caring for her partner with an unknown cancer explained to us that queers are excellent caregivers, but we're just stretched really thin. We've got other stresses in our lives: trauma, discrimination, underemployment, unstable housing, violence, mental health issues. So when you add cancer in on top of that, there's just not enough of us to go around. Some people also told us that they withdrew from the LGBTQI+ community when caregiving, as they were just utterly exhausted and found it difficult to connect. But it's not all doom and gloom. We actually heard really amazing stories of people who had really strong support and were really resilient and had amazing coping strategies. So 71% of LGBTQI+ carers had strong support from family and friends, and that was highest for older adult carers. That's to be expected. People have had more time to develop community connections and build their relationships and friendship groups. So that sort of makes sense to me. And what people said was that although caregiving could be challenging, it brought people closer, it facilitated strong relationships, and there is a culture of mutual caregiving in queer communities. So this 76-year-old lesbian who was caring for her partner with ovarian cancer said that being part of quite a large lesbian community, people rallied around them and supported them whenever they needed it. And that was beneficial in terms of emotional well-being and added to a feeling of not doing this alone. A number of people, there's a couple of extra photos I've added in here of people taking on advocacy roles in our community and making sure that cancer awareness and information is spread through queer networks and pathways. So really incredible ways that people connected to provide support to each other and to make sure that cancer carers were looked after. And of course, and I'm sure this is common across all cancer carers, but this was just a really touching interview that I had, was that, you know, cancer caring affirmed relationships and brought people stronger. Often queer people have been through so much together, and when cancer's added into that, this person described it as a dreadful challenge, but it made us just really understand our love for each other and rely on each other more than ever before. People also described it as a gift, and although it's hard work, you have to care for the person that you love. So changing track a little bit, I just wanted to mention another part of the study that we'd done, which was a review of Australian cancer websites to find out if they mention LGBTQI people, and if so, what information they were providing. So we reviewed 61 websites, and we found that only 13% actually had any content at all that mentioned LGBTQI people, and that there was a dearth of information here for transgender, intersex people, and also for carers, particularly LGBTQI+ carers. And as you can see from what I've just presented, there's some specific needs that we need to address. So with all this information together, we've been working with our partner organisations to develop patient and carer resources and information. So these include 12 information pages with Breast Cancer Network Australia on the My Journey app, with information for LGBTIQ+ people diagnosed with breast cancer, and an 82-page booklet with Cancer Council that includes specific information for LGBTQI+ people with cancer. And these, of course, include carers as part of that. So I've spoken as quickly as I can. I hope you were able to follow me, and I didn't rush too much, but I wanted to include as much information as I could. I guess in summary, LGBTQI carers, we know that they've got to contend with the typical caregiving demands, but whilst also managing minority stresses linked to being LGBTQI. So things like discrimination, rejection from family, isolation from LGBTQI plus communities, and invisibility in healthcare and support services. So it was amazing to see all the ways that caregivers showed up and the resilience that they had in building community and networks and rallying around each other to provide support during such a difficult and vulnerable time. Thank you very much.
Thank you so much, Dr. Power. That was very, very interesting. And in fact, I was reflecting as you were talking on my own experiences supporting people with neurodegenerative palliative disease and the difficulties that people from the LGBTQI community had, and the hidden trauma that is sometimes sits beneath the other experiences that they're having. And I think it's very powerful and really interesting work that you're doing on behalf of us. The other thing that struck me is it's a reminder that all carers are not the same. You know, we can't take a homogenous approach to supporting carers, because while there's a commonality to what we do, there's very specifics to each and every one of us. And I think your project recognises that. So thank you very much.
Thank you.
And I'll just remind everybody to pop any notes into the Q&A section, and we'll pick those up and answer those at the end. And without too much waiting, I'm going to pass you over now to Marie Montgomery. Now, Marie is a clinical nurse consultant in the Murrumbidgee Local Health District with a background in acute emergency and intensive care nursing beginning in 1983, during which time she's been a very strong advocate for vulnerable people navigating the heightened environment within emergency and intensive care units. This is also something I'm particularly interested in because they're very difficult spaces for older people. She's worked proudly with the national peak body, OPAN, the Older Persons Advocacy Network, to co-create an e-learning module for health professionals around the abuse of older people. And she's currently working on a redesign and innovation project in palliative care with health professionals, clients and carers to improve access, equity and voice in palliative care, which she'll be speaking about today. Over to you, Marie.
Thank you so much. And look, thank you, Rosalie. That is extraordinarily powerful, the message that you have presented today, and I thank you a great deal. Today I'm going to talk about the importance of connection in rural New South Wales. I'd like to acknowledge the Wiradjuri people of the land that I come from today, and acknowledge all elders out there watching as well. I'd like to talk about palliative care briefly, and this comes from the End of Life Palliative Care Strategic Framework, New South Wales Health. And it is care that optimises the individual quality of life for individuals, their families and carers approaching and reaching the end of life. It's specifically about reducing suffering and promoting dignity. But more importantly, if we really just pull that apart, it's about providing that quality time together. And again, Rosalie mentioned in many of her quotes the importance of that time together and the importance of caring and celebrating life and memories. This also, palliative care is across the lifespan. There is no age particular time, although we do think and feel that it is predominantly with the older person. Not only is palliative care uniquely individual, it's also very contextual. And again, to draw on Rosalie, it's about promoting that individual and including them into that conversation. Their goals as well, that you mentioned, Karen, is so important that we bring those goals into those last days of life. And those last days of life may be years. Those priorities, 5 priorities, and as we mentioned, the care is person-centred, and I understand your frustrations with this because it's often a mother statement, and if not necessarily applied at point of care. The other priorities are that there's recognition and support for families and carers, and this is exactly what I'm drawing on today. Obviously, that there will be access to palliative care across all settings, and that the care is well coordinated and integrated, and access to quality care is equitable. Now, we'll look at the next slide, and we can see that Murrumbidgee is an extraordinarily large health district. And from the modified Monash model, we go into remote as well as large community regional areas. It covers approximately 125,000 square kilometres, which is about half the size of Victoria. So it's very large. It covers a great deal of mountainous and also out into the savannah and the plains. The age and sex distribution is very similar to those of New South Wales, and we can see that we have above the rates for New South Wales for carers and also our First Nations people. So it is an area that is required. There's a lot of distance, there's a lot of service provision nuance, and particularly for carers, they are extraordinarily isolated. Palliative care is often GP driven, community supported, and rather ad hoc. So we have a lot of work to do in regards to providing that service literacy, service navigation, and coming together and connecting and identifying our wonderful carers across rural and remote areas of New South Wales. So the Carer Coordinator Network is a new role that we have created out of the end of life, enhancing end of life funding. This is a state-based funding, and the idea came that many of the things that you have talked about, the isolation, the lack of ability to work, the opportunities to socialise, because often we're with the carer, so we de-identify, we lose ourselves as carers across this area. And one of the things that we found was really came through in some of our surveys was that no one knew where the services were necessarily or how to connect with them. And we wanted to have that bridge where we created point of care approach to coordinate. So we've employed a palliative care coordinator, a full-time, and the first process of implementation is, I'm not as great speaker as Rosalie, so I do apologise. The first implementation is in regards to a carer identification. This is really, really important. And because a carer is not necessarily next of kin, a carer, as again, sorry, Rosalie has brought up, is it can be across a whole domain. So the first thing we are doing is integrating a carer acknowledgement within the administration form and in part of our part of our records, electronic records. We then realised that the area was so large, where are also some of those connections that we really need to tie in. And there are some wonderful services, but we are siloed, and it was about de-siloing and really coming together to find supports for carers to navigate that services and really assist them to find them. So we felt that on discharge, on admission, on discharge was a really good place for carer identification and acknowledgement. Then also within the GP, and we work closely with the PHN to educate and support GPs. We are looking at a self-assessment carer tool. Again, the research suggests that carers do not acknowledge themselves as carers, and we would like to celebrate carers and support. So again, this is the first pitch that we've done for this particular carer network. and I would love any feedback that you have. We would provide, with Carers New South Wales support and resources, an extension of the psychosocial supports for carers so that they are not isolated. We can use virtual care for sessions within their home, and also we could utilise our palliative care staff to provide that health-based, really, what is being a carer about, you know, talking about medications, the syringe driver that you may have, the different positioning and approaches to movement, those 101 carer-based point of care that if you're in Tooboolewuk, you may not have anyone there to guide you. So it's about really guiding new carers or carers that have been doing it for a long time to support them as carers, to provide that physical care. Other areas that we're looking at are residential aged care. There's a high number of carer workers within residential aged care that also would like more understanding around palliative care, but also how to support the carer within challenging conversations, within conversations around celebrating that person's individual's life, about really having, you know, the conversations about where they would like to die, how, and taking some control back on how the person will die. The other thing is around the carer is often going through bereavement after palliative care has finished. And so for us as palliative care, it's really, really important that we acknowledge carers earlier on in the grieving process, that we have those conversations on the individual carer's point of view, and what sorts of supports would be important initially, 3 months and 6 months post the person's death. Again, this is all coordinated from Murrumbidgee. We are really hoping to tie up all those loose ends, and practically, this is where I'm taking what I find our research to come across and practically bring this into people's homes. Our success criteria will be that there are obviously increased carer identification, and they're validated as a partner in care, and that they're validated as a really important process for us to work together in providing that care and supporting them. That we really want to increase our reach. We have a huge geographical region. We have a lot of carers, and we really need to collectively get together and help find, identify and support carers across regional New South Wales. We're really wanting to bring about some systemic change, and some people might notice that language from a recent grant application, but it is really about just finding who's who and linking everybody together to take that away from the carer themselves, because it is a huge undertaking to navigate. Partnerships with other organisations, particularly Carers New South Wales, demonstrate our capacity and capability to improve carers' wellbeing and health. And we are running a potential pilot study on the actual process itself. So the overall enhancing end-of-life funding, I just thought I'd do a little bit of a snippet on its background. And it is quite a large palliative care supportive process across New South Wales. And one of the biggest areas that I have focused on as the lead in Murrumbidgee is that consumer and carer choice. So strengthening the support for carers and individuals across Murrumbidgee. So that's me for the day. Thank you for listening.
Thank you very much, Marie. That was a wonderful topic, and again resonated quite well with me. I was thinking back to my father's experience and a bit of my earlier commentary around person-centred, well out from before Dad became technically palliative. My mother and I were called to have a conversation with the local palliative care team about what his end-of-life wishes were. But in that conversation, my mother was incredibly confused about why they were asking her that now, because in her mind he wasn't dying, and probably in her mind he was never going to die. But there was a lot of talk about advanced care plans and DNRs and all the rest of those sorts of things, which my father used to change his mind about all those things with quite some frequency, or nobody could ever catch up. But the point was, in that initial conversation, nobody included him in that conversation to ask him what he wanted and how he thought his end of life was going to be. When the time came, we were in those last days and that end of active dying phase, he wasn't in the place that he would have chosen to die. However, we had a wonderful nurse, head of unit, who very stoically clung to the principles of couplehood and spoke with both my mother and my father about how they wanted things to go. And despite a lot of opposition from geriatricians and bed managers who wanted to move him somewhere else, she clung to that, and he ended up having the most wonderful death in the end. And I think that's a bit of an exception, and it comes down to individuals, and the work that you're doing is going to help create spaces where those individuals can actually stand up and have the evidence behind them to do it, and provide a real voice for older Australians, which quite often is missed, particularly in those last conversations. So thank you, Marie. I will be watching that project with a lot of interest, and I wish you all the best for that. I know you have to take off. Is that right? You're leaving us now?
I will leave shortly, yes. I do apologise, but yes, thank you for your time and thank you for the opportunity. And yes, I'll have to meet you in Murrumbidgee one day.
You will do. And so, Marie, what we might do, if there are questions specific to your project, we might gather those up and send them to you and answer them in another format, but we'll make sure that they get acknowledged. So now it's my pleasure to introduce to you Dr. Louisa Smith. Dr. Smith is a senior lecturer in disability and inclusion at Deakin University. Louisa's research interests centred on the relationship between experiences of disability across the life course, complexity, social policy and social change. Her research works across the disciplines of sociology, disability studies and policy studies, and she approaches all research and teaching as a means of fostering social inclusion and belonging through co-production, arts-based methods and knowledge translation at all stages of the process. And today she's going to be speaking about one of my other favourite topics, the NDIS, around planning and a new resource she's been developing. So thank you. Over to you, Dr. Smith.
Thank you very much. Thank you so much for having me. I've been actually really affected by those two presentations and the incredible, personal nature of both of those for me as a lesbian woman and as someone who's experienced palliative care. So bear with me. I'm a little bit jumpy. As was said in the thank you for that, love heart. As was said in the introduction, this paper is really based on some work that we've been developing as colleagues at Deakin and previously at UNSW around supporting people from refugee backgrounds who have disabilities and their carers. And we've been doing that work for about 5 or 6 years. This project that I'll be speaking about today is particularly focused on co-designing resources which were aimed at improving access to disability services and in the end, because of the co-design process, actually around carer services as well, but I'll get to that in a moment. So a really brief, I'm not going to spend long on the background because I was told not to, but very briefly, I think it's really important to know that in 2012, we had there were changes in the humanitarian visa health waiver for Australia, in Australia, which meant that for the first time, people with disability from refugee backgrounds were granted visas. Basically, no longer was the cost of health burden taken into consideration in terms of humanitarian visas. So when we first started doing this work, which was really coincided with this period, refugee services were and resettlement services were completely flummoxed by this incredible onslaught is a dreadful way of explaining it. This new group of people from refugee backgrounds who had disabilities who they'd never encountered in resettlement services before. And so really working early on with Starts and then increasingly in New South Wales and then with Foundation House in Victoria, we've been over the time developing up resources, understandings of what the experience of disability is like for people from refugee backgrounds. Particularly, we've focused on Syrian and Iraqi people from Syria and Iraq. We know that there is we actually don't know very much about what the experience is like for people in their countries of origin who have disability. We know there's incredible stigma around disability, that often people spend a lot of time in transit countries where they receive various degrees or supports around disability, but often disability remains very hidden. There's so much shame around disability for both the carers and the people with disability themselves that there's not a public discussion, and people often remain incredibly socially isolated. There's also not disability supports, so there's often not access to just basic public and health services. And we also know that the stigma is so great that even when people arrive in Australia, there's a real reluctance to seek services or even acknowledge that those systems and services exist. So, as I said, this study was funded by a National Disability Research Partnership and a grant, and this is really aimed at co-designing resources which we recognised through our early work were highly necessary for Syrian and Iraqi people from refugee backgrounds who had disabilities to be able to access really basic services. This had four stages or steps, as is illustrated on this this triangle here, this arrow here. I'm really going to be focusing today on step 2 and step 3. We're yet to do the final kind of dissemination of the co-design products, but we have been doing a lot of dissemination throughout the project. At the very heart of this project is what we call inclusive co-design. I mean, all co-design should be inclusive, but we find that we need to add that word, particularly if we're talking about people with disability, because often there's not the kinds of engagement strategies that would really support people with disability to be involved in co-design processes. So there were a number of ways that we engaged in inclusive co-design in this project. The first was that we employed for 3 days a week, a part-time project manager and co-researcher who had lived experience as both a refugee from Syria and as a person with disability. And that's Mahmoud Murad, who is a co-author on this presentation. Unfortunately, he can't be here today because he's now a local area coordinator for the NDIS, which I think is a wonderful outcome or part of this project, a story of this project. So Mahmoud was pivotal to the success of this project, in part because he's a leading disability advocate in the Arabic-speaking refugee and migrant community around disability. He'd already, on his own bat, established his own website about disability services in Australia, which is in Arabic, to overcome a lot of the challenges that we were really trying to address in this project. So an incredible resource. There's an image on the screen, which is a hand-drawn graphic image of a man holding a suitcase. This is an image drawn by Nassan Isbar, who is also a man of lived experience as both a man with disability and from a refugee background. He's been unable to work in Australia largely because he doesn't speak English. And so the fact that this project was conducted entirely in Arabic allowed him to use his skills to graphically illustrate all of our workshops, and as you'll see, also help produce the outcome of some video resources. We also had two people with lived experience do the voiceover artistry in the videos, Nassan being one of them, the graphic illustrator, and a carer, a woman who's a carer. An incredibly pivotal part of this, and I think it goes to what Rosalie was talking about, is the constant engagement with partner organisations to ensure that these anything that we do in this project is already embedded in and becoming embedded in practice, but also we're benefiting from the safe places that have been created by partners. So we see that we had a partnership with STARTS and Foundation House and SSI, Settlement Services, I forgot the last letter, and SSI and a disability service, Disability Trust. And all of those organisations provided bilingual workers to work with us throughout the whole process. So the second step of this project was really focused on doing some workshops to help establish what are the key areas or challenges for access and what supports access. Now, any researchers in the room will understand just how amazing this is, that within 24 hours of advertising this project in Arabic through our partner organisations, we received 38 people responding. So the need to talk, to come to Karen's point earlier around the need for carers to connect, was so significant that people responded within 24 hours to be participants in this project. And that's because those workshops were conducted in Arabic. You could also be anonymous, you could be online, or you could be in person if you're in Melbourne or Sydney. The kind of primary thing to come out of not only that, but out of these workshops, the overarching issue was both that that it is so difficult to access information, resources, to actually get access to services, even if you're actually in them, but to get what you need if you don't speak English. And in addition, most people in our workshops, carers and people with disability, were not literate in their language of origin, and definitely weren't literate in English. So the idea that you could go to Google and search up a service or a support or navigate a system or even find the Arabic, to do that, you need to search in English. People couldn't search in English, and they couldn't actually search in Arabic either. So resources that were available in print were completely useless. In addition to this, there was incredible obstacles to language learning due to both carer responsibilities and a lack of understanding of disability and disability learning support within English learning contexts. We've actually written a piece for the conversation around this, and I've put the QR code there if anyone wants to scan that and have a look at that piece, just so that it's got a lot more detail and some really powerful quotations from carers and people with disability themselves about their experiences. So this is literacy, literally literacy, not just literacy of services. So from those workshops, people really wanted to have access to resources that were in Arabic. So they wanted them to be videos or visuals. There's no point in having huge amounts of text. They really wanted those opportunities to meet with peers, other people who, particularly carers, really wanted to meet with other carers who spoke Arabic and who came from not even necessarily refugee backgrounds, but came from migrant backgrounds who could share and through that, and meet those people through trusted channels. So when we, for instance, we got in touch with Carers New South Wales, I early on got in touch with Carers New South Wales and said, oh, could you come along and help? There was a real reluctance from the co-design group around carers to actually connect with Carers New South Wales because they weren't a trusted provider. And they weren't sure that they would be culturally competent. So services really needed to demonstrate, services like, you know, Carers New South Wales and other carer support organisations. The idea of going through Carer Gateway for this group was just completely unreasonable. Instead, those services needed to really reach out and show that they were competent culturally for them to feel safe. Those workshops also identified 4 key priority areas that the carers and people with disability themselves really wanted information about and wanted to have more clarity around. Not surprisingly, given the challenges that everyone faces around accessing the NDIS, the NDIS was one thing that people really wanted clarity around and wanted resources that were in Arabic, video resources in Arabic around that. And more than that, video resources that also understood the kind of added challenges or particular barriers that people from refugee backgrounds might experience. They wanted information about health. Just the idea of our healthcare system being separate from our disability support systems is really strange. But also, how do you access health? And particularly what became clear as we moved further through the process was that there was a particular interest in oral health and accessing oral health, which of course is not within the regular Medicare system as well. An overarching thing was family stress. And then we also had a concern around housing, and particularly the intersection between housing and the interface with that and disability supports. In the end, the co-design groups, which were made up of 15 people with disability and carers, as well as some members of partner organisations and bilingual workers, came together and they got to choose which of these they wanted to work on. They didn't decide, no one chose housing. There were people who chose NDIS, health and family stress. So in the end, we ended up producing 3 groups of resources around those things. We made 6 videos about in Arabic about the NDIS, which focused on topics that people decided, and I'll talk to that in a minute, and 1 video on the carer journey and stigma, access and possibility. And I'll be focusing particularly on that because that was the co-design group that I worked with very, very closely. We also produced, which I haven't mentioned here, a postcard on oral health, which provided links to a whole range of resources. And we did a valid Victorian advocacy group ran a half-day introduction to family succession planning, which was done with an Arabic interpreter. And this was because succession was a huge concern for most of the carers. And by succession, I mean, who's going to care for my family member when I can't? So, as I said, it's not particularly surprising that the NDIS videos were needed to cover everything from what is the NDIS to some much more complex issues around how do you ask for a review of your NDIS decision and how do you make a complaint about an NDIS funded service. And I think it's really, really important to emphasise how big this issue was at the end, this idea of making a complaint. And this became a really big passion for our co-researcher, Mahmoud, who wrote an incredibly moving, who couldn't actually speak about this, much in the way that I couldn't speak at the beginning of this session, couldn't speak about this in person, and instead wrote incredibly moving email to the other researchers on the team about just what complaint means in a country like Syria, that you would never make a complaint when you're to a government agency. That idea is just completely contradictory in a terrorist, in a country where there is so much terror, there's so much conflict. The idea that you would do that is completely against what people can culturally understand. So we had to work really hard around making that video in a way that that people could begin to do those, could begin to make that complaint. You can see one of the really powerful drawings that came out of the work there, and this was made in one of the workshops, where there's this barbed wire fence between the NDIS and the child at school, and this is one of these the interface principles of the NDIS mean that the NDIS doesn't provide support that education should provide in a school environment, but that separation is very, very difficult to negotiate and often quite arbitrary. I'm just going to show you an example of just a little bit of the video. I won't show you the whole thing, but.
تم إنشاء البرنامج الوطني للتأمين ضد الإعاقة في عام 2013، حيث ضغط العديد من الأشخاص من ذوي الإعاقة من أجل نظام وطني جديد لتمويل الإعاقة.
تديرها وكالة حكومية مستقلة تسمى الوكالة الوطنية للتأمين ضد الإعاقة، وهي متاحة في جميع أنحاء البلاد في كل ولاية وإقليم.
تساعد NDIS الأشخاص الذين يعانون من إعاقة دائمة وكبيرة في الحصول على الدعم الذي يحتاجون إليه حتى يتمكنوا من عيش حياتهم.
الإعاقة الدائمة والخطيرة تعني شيئا يستمر مدى الحياة، وليس شيئا سيشفى قريبا مثل كسر في الساق.
تعني كلمة كبيرة أن الإعاقة لها تأثير كبير على قدرة الشخص على إكمال الأنشطة اليومية مثل الاستحمام وارتداء الملابس أو الخروج والتجول في المجتمع أو إدارة الأموال أو الوصول إلى احتياجاته.
I won't play the rest of the video. It's about 3 minutes long. Apparently I will. But what I think is really, there's so many significant things about that video, but we're using their Nassan's drawings. And one of the things about his drawings, which become really obvious as somebody who's worked with a lot of illustrators, is that I always spend a huge amount of time saying to illustrators, oh, please, can you not represent disability as someone in a wheelchair or someone with a prosthetic? You know, that's just not what most people with disability experience. And Nassan didn't do that at all. The diversity in the people in his drawings, the kind of complexity in the way that he represented disability really, really showed how how complex lived experience of disability is, but how important it is to have someone with lived experience doing representation from within. I'm not going to show you this next one, which is about the complaints, just that I will send on. I'm happy to send. We've actually just got these videos produced, so I'm happy to send them on, but we don't have them yet available in YouTube, which we will soon. But I will. I'm just going to skip over that. To get to my the kind of key for my group, I worked with a group, and they were all carers of people with disability, and actually all carers of people who were under 25, and so parents. All of them were parents. And what was really interesting about working in this group is, unlike the NDIS, where it was very straightforward in many ways around just what information needed to go in each video, and other than that issue around complaints processes, it was pretty straightforward about, okay, this is what we have to do. That was not the case with the carer video. The discussions that we had about what people wanted to include were vast and wide, and the concerns and kinds of stress that carers experienced was quite profound. Just the diversity of that really crossed across all areas of Maslow's hierarchy of needs. If you're familiar with that, from things like from those really basic, really fundamental things around housing, right up to how do I actually do something for myself, given the incredible demands that I have on my life. there were startling comments, such as the first quotation here from a carer who said, "Whatever I experienced in my country is nothing in comparison to what I experienced from the NDIS." And here, what he was talking about was really the kinds of the incredible difficulty that he had in accessing the NDIS and getting, despite where he really felt like this incredible frustration and anger around never having his needs met, going to everyone knowing that he needed an interpreter in terms of his file and turning up and there not being one. And just in terms of these co-design groups, which were all happened in Arabic and were not simultaneously translated. So I was often just sitting back and waiting for people to tell me what was happening. Everyone made him stop when this was said in Arabic and said, "You've got to translate that for Louisa." And so they translated, because all of them resonated with that particular comment. But a really key thing is that none of the carers realised that they could get support for themselves, even though they experienced incredible stress and mental health challenges in regards to their caring. And when I asked what was the best support they'd ever experienced, 3 of them said being a part of the group, the co-design group, was the best carer support they've ever had. In other words, they haven't really had any support as carers, and this was the first time that they really got together to talk to other carers. We navigated a whole lot here too around people who had really, really different experiences of disability and were at different points in their understanding of disability. And so some people really had incredibly deficit ideas around disability and really didn't see that the person they were caring for would ever be able to do anything, in comparison to people who really did a lot of kind of almost capacity building with those people in the group to talk about, well, I used to feel like that. And then when I came and saw the way that to Australia and saw the way that the support workers worked with the person with my son, suddenly now I feel really ashamed that I treated him, that I didn't think that he would ever have a good life. So there was a lot of kind of sharing and very much what Karen spoke about earlier around sharing and real change that occurred around people's attitudes towards disability within that short period of time. And so we really tried to capture that in the video, people just really talking about wanting some hope. And so we tried to capture that in the video, and I will share, I hope I have time, the whole video, which is 3 minutes, and then potentially that will be all.
في العديد من الدول ينظر إلى ذوي الاحتياجات الخاصة وأسرهم نظرة سلبية تشوبها وصمة العار، وكنتيجة لذلك تبقى الإعاقات في الخفاء وغير مشخصة، ويبقى صاحب الإعاقة بدون دعم.
لكن ذوي الاحتياجات الخاصة ليسوا أقل أهمية من غيرهم في المجتمع، بل يشكلون إضافة إلى التنوع الإنساني.
في بلدي الإعاقة معيبة، تبقى طي الكتمان. أنا ألوم نفسي. عندما جئت إلى أستراليا كلاجئة، كنت أبقى بالبيت لرعاية ابني وتلبية كل احتياجاته، وبسبب ذلك لم أستطع حضور دروس تعليم اللغة الإنجليزية ولا التعرف على أشخاص جدد في بلدي الجديد.
في أستراليا يتساوى ذوو الاحتياجات الخاصة مع غيرهم في الحقوق، يشمل ذلك الحق في التعليم والعلاقات الاجتماعية والتوظيف. تتوفر الخدمات لمساعدة ذوي الاحتياجات الخاصة ومقدمي الرعاية.
لم أكن أعرف بوجود خدمات لمقدمي الرعاية. كنت أشعر بأنني منهكة روحياً وذهنياً. ذات يوم التقيت بسيدة تتحدث العربية بينما كنت مع ابني خارج البيت، وسمعت منها عن الدعم المتاح، ثم سجلت في دورة تعريفية باللغة العربية عن الخدمات المتاحة لذوي الاحتياجات الخاصة ومقدمي الرعاية، والآن أمام ولدي الكثير من الفرص، فهو يراجع بانتظام أخصائي النطق، ويستطيع كذلك التعبير عن نفسه بواسطة جهاز لوحي آيباد. كما وأصبح لدي الآن صديقة تعلمت منها أن علي الاهتمام بنفسي أولاً لأكون مقدمة رعاية جيدة لابني. بفضل خدمة My Refugee Service أصبحت الآن على اتصال مع نظرائي من مقدمي الرعاية الذين يتحدثون اللغة العربية عبر مجموعة مقدمي الرعاية، والتي أشعر من خلالها أنني في مكان أستطيع فيه مشاركة الصعوبات والتحديات التي أواجهها مع أشخاص يتفهمون ذلك. لم أعد أشعر بالعزلة، بل أشعر بأن هناك أمل.
I should have said before, thank you everyone. I should have said before that all of the text in that video was edited together from the transcripts of our workshops and of our focus of our co-design group comments. If I have a moment, I'll just take a moment to finish off. I think what I can't stress enough is the invaluable contribution of the lived experience within this co-design group in terms of access and literacy. There is no way that we would have been able to even access the group that we accessed unless we had a person with lived experience who spoke Arabic at the centre of this project, and who really could engage with all of the kinds of literacy that were necessary to make a resource that would actually be received well. And when the co-design group saw that final version, they 3 of them cried, because it was such a beautiful representation of what we had done together, but also because it's the first time that they had seen themselves reflected. There was incredibly high level of powerlessness, and I think that's reflected in just how powerful this process was. And that was despite the individuals and all of the people being actually incredible advocates, and really learning incredible advocacy skills within the system. And despite that, they still came up against loggerheads, particularly because of English literacy. That I think the other thing that was really important to understand is just how much these ideas of access and literacy really were about going on a journey with people, not just about creating a resource. That you can't, that the resource at the end is that product is not the only thing that we need to be engaged with. That really we needed to take people with us as we went, including the partner organisations who really needed to develop their skills and knowledge around both for disability services, around refugee, and it's like they were startled that people were illiterate. So that was really interesting. Whereas the refugee services just really needed much more knowledge around the NDIS. So I will conclude there, but I'm really, really excited to answer any questions. This is the first time I've presented on that final video, so interesting.
Thank you, Louisa. I've been a very bad chair. I've let you go over, but
Oh no, I had my timer gone, but it didn't go off, sorry.
It was such an amazing presentation, and having worked in the NDIS space, knowing how complex some of the languages we use around that system, how that is ever able to be translated to other languages and for other people to wrap their heads around it. I can't wrap my head around half of the things. You know, I was just sitting here thinking, how do you explain what a review of reviewable decisions is, or a change of circs, or a core support as opposed to a capacity building support? It's an incredibly valuable system, but it's also genuinely very hard for people to understand. Yeah. And so thank you so much for that. The other complexity that sprang to mind was people that I've worked with from other countries who it's not culturally acceptable to tell the person with a disability or a chronic health condition that they have that disability and that makes it very difficult for carers to actually fulfil their caring role. And if we go back to that sort of person-centred system, most of our systems insist that the person themselves has the conversation and authorises things, and that's not always culturally appropriate. So I think the work that you're doing is so powerful and so needed. And I especially loved that at the end you were able to validate what I'd said earlier about learning more from carers, and just that power of being able to get together with other carers and talk. And I can remember an instance when my son was very young, and I was talking with the mothers after a soccer practice, and one of the mothers yelled to her son, "Stop licking the fence." And all the mothers kept talking because we're all autistic mothers, and it was just normal. And I thought in that moment, it was so lovely just to be comfortable about your child licking a fence, you know. And it's that once you're comfortable, and then you can talk, and then you can learn, and then you can share, and then you can grow, and then we develop this thing that we call in service literacy. So thank you so much for the work that you're doing in this space. And if I can call Dr. Power back to join us, we do have some questions. Yep, lovely, thank you. And I think we've got some time to answer those. I do have a question for you though, Louisa. I have been a support coordinator at one time and had a team of support coordinators under the NDIS. Did you have any interaction with them, given that people in your interest group would probably be provided with funding for a support coordinator, because that would be the most obvious thing for them to do if they were going to get through it. Did that come up at all, or was that talked about?
It did come up, but the support coordinator was only useful when not all of them had one, so I think that's important. But it also, very few spoke Arabic, and so what was happening was that often the refugee services were taking almost those support coordinator roles, even though that wasn't their role, because they could do the navigation of the system with somebody. They had a lot of bilingual workers who were actually operating in that role, and that the problem with that is that stops at a certain time after the person has settled in Australia. And so it's interesting now that SSI actually has a local area health, a local area health coordinator, like a local coordinating role, which is really, really valuable, because it means that they actually can be a bridge between. That wasn't the case when we started this work. That's only been recent. So I think basically no, that didn't really help to answer the question. Yeah,
it's interesting. I mean, the government's looking at funding care navigators in the My Aged Care space, and I think we come up against exactly the same issues, because they won't be culturally specific or appropriate and have that background and be able to translate. Sorry, that was just a little interest of mine. I've got the questions here. So somebody said here, Libby has said, such an important project, Louisa, thank you. How does the NDRP work intersect with the NDIS called strategy?
Good question. Can't answer that right this second. It does, and we have written about it a little bit, but I can't actually remember what we said. I think one of the things that we really were focused on with this project is really listening to what people really wanted. And I think one of the gaps that we found was that just so much was still done it still required people to be able to be literate. And that was a huge issue. And I do think from memory that's missing from the COLD strategy. That this idea of really producing, really bridging those gaps. It's okay, we can produce materials in different languages, but to actually be able to get to those materials was impossible for people. And then when they got to them, they were nearly always written. So those kinds of those gaps were so significant, and even people, you know, yeah. So I'd say that I'm sorry that I can't answer that more articulately. I haven't read it recently.
But I think that also speaks to the fact that we have all these policies and best practice, but actually trying to match that, translate that into real outcomes for people, things that they can practically grab a hold of. That's the difficulty that we've got. We all know what we want to do, which is how do we actually make that happen. I do have another, I'm sort of sorry, pardon me for flipping through the questions that are coming through, but today's session's been about service literacy for carers, and quite often that whole concept of a carer's service literacy then puts the onus and responsibility back on the carer, and to know and understand how everything works and those challenges. And obviously they feel like they're illiterate. Can you be something, such a thing as service illiterate, or is it just a continuum of knowledge acquisition? I'm not sure. Rosalie, if you've got a thought on that?
I'm not sure if I know the answer to that outright, but I guess it sparks for me this idea of, where the onus sort of sits, and making services culturally, inclusive, culturally accessible, safe. That really needs to come from service providers. They need to be the ones being proactive in bridging those gaps. Carers have already got so much going on. And for all the reasons that Louise has explained, it can be really hard for people to find out information. For me, it's sort of, I don't know about the concept of service illiteracy, but I think the onus of that needs to sit with healthcare providers and services.
Yeah, and I would add to that. I mean, it's something that you said earlier, Karen, and I actually had it on my last slide and took it off just before. That you really don't know until you don't know, and most carers, like most people who are experiencing, the systems, are experiencing them for the first time. So you're really coming into something. You keep coming up against new things. And we see that in the disability space, and we see that in the aged care space, I think in particular. And what happens in that is that you have to learn very, very quickly a whole lot of things that you need for that moment, and then you need to learn again the next set of things, and the next set of things, the next system that you encounter, and the next system you encounter. But if you flip that around and think about, okay, well, what can the service do to actually make this not about, so that they are actually supporting literacy? How can they, it's like an easy read document, right? Like, it's really not the responsibility of the person who comes to that to have the capacity to be able to read it. It's that you need to make that accessible.
That's right. And I think that example you gave earlier of a review of a reviewable decisions, I myself have been through that process with a family member, and I think between us we had about 8 degrees, the people trying to work it all out. It was very, very stressful and very, very complicated. And we really struggled, and all of us are, English speaking as our first language, university educated, and have had huge opportunities for education. So it just sort of makes me really concerned and worried for people who are coming with other barriers.
Absolutely. Yeah. And if you think about like that complaint process, so one of the men in our co-design group, a father, finally, really worked through this kind of idea. Okay, I can make a complaint here in Australia, and really to do that was huge. And he made a complaint, and then he got no reply, and he does not speak English or write English. So for him to then, he couldn't follow up because he didn't, that he'd already done it, that kind of administrative burden. So I think that's, really significant.
Yes, I agree. And thank you both, because quite often as a carer, you go to a service provider and you feel like you need to be able to tell them exactly what you want. And I agree that the onus needs to be on the provider. Now, I've missed out on services, and I don't think it's any ill intent of providers or any of the health professionals I've dealt with. It's just that unless people are asking the right questions in the right way and taking the time to unpack what somebody's really asking for, then you don't get directed to things. And I've had experiences where, like, even years later, I've said, oh, we could have been accessing funding under XYZ. And the person said, oh, yeah, that's a great program. Well, why didn't you tell me about it all that time ago? I found out about that when I was, finishing at the speechy with my son, like that's the bit that can cause huge frustrations for carers. And then you sort of think, well, what have I done? I've ruined my son's life because he's missed out on 3 years of this additional fund. There's a lot of responsibility gets put onto to carers' shoulders, and you already feel responsible for making decisions for families and all the rest of it. So, yeah, I was just wondering about that. I know I'm watching time because I've already messed up once. Dr. Parry, your work focuses on marginalised communities. How could further research reduce barriers to access for members of these groups? Where do you see the next step being?
Yeah, look, I think listening to Louisa speak as well, I think we seem to approach research in a similar way using co-design approaches. Our research tends to, I don't know if you, Louisa, but it tends to be a little bit slower than perhaps other forms of research. And we spend a lot of time building relationships and connections with people and trying to get people in the room that are really hard to access, that you just don't often hear the voices of. And I think getting those people in a room with service providers and policymakers is just absolutely invaluable. And I think taking the time to do that, forge those relationships is what I see as really crucial. It really strengthens a co-design process. It allows you to create solutions that are way more creative and that address problems that you can't know of yourself, because how would you know unless you hear those experiences? So that's my take on it.
And I think just to add to that, with our project, we suddenly got all these people in a room who had never spoken out before. And in the end, we supported them because we have a different access to power. We supported a large group of them to go to the Royal Commission, and actually we organised a private meeting with the Royal Commission into disability that was in Melbourne. When they were taking private sessions, we organised, I think it was 10 people to speak in Arabic about their experiences. So I think that there's that that's the other thing that can happen when we do this kind of research, is that we can broker connections that didn't previously exist, which I think is what Rosalie is talking about there, in really productive ways that actually can make different kinds of changes than what we expected. We did not expect to be doing a piece of work on carers. That was not at all our intention. All of us are really, really disability focused in terms of, actually in disability studies, there's a real emphasis on not doing work with carers. And so it was the push really from the project that made us go down that avenue. And I think that's really important for everyone to keep in mind, that actually you need to be following the agenda of the consumers. I hate that term, but that's
yeah. And look, and that goes back to my earlier point at the beginning of this session about person-centred, because person-centred includes the whole person. It's not just about a discrete bit of their lives about how they shower and dress and toilet. It's about how they live socially, psychologically, emotionally, all the rest of that. And that includes the carer. And that, I think that was one of the shortcomings when the NDIS and even My Aged Care rolled out initially, because it excluded advocacy and it excluded carers from that whole conversation.
And respite.
And respite.
Yeah.
And, I can remember the first time my son was asked by an LAC what he wanted. He just looked at it like he had 10 heads, because he'd spent the first 18 of his years of his life being told what he could have. Nobody had ever shown him how to ask. And so
yeah, what a skill set. Yeah.
It's a whole new skill set that somebody has to learn. And so and all of these systems, if you don't ask, you don't get. And so we had to somehow support people better to know how to ask. And I guess this is the other part of service literacy.
Yeah.
Now,
and I think it's on all of us to, oh, sorry, did I cut you off?
No, you go.
I think it's on all of us to look around the room and see who's not there, and to try to ask ourselves the question, why, like, who's missing and why, and what, should they be here too, and what can we do to get them here? Yeah.
did you have a last concluding point?
No, you go, Karen.
No, I was just going to say thank you to you both. I know there are other questions. We will collate them and get some information out to attendees at some stage. And just a reminder to everybody that all the sessions across the 3 days are being recorded, so you can log back in and listen to the very excellent presentations. And I'm sure Marie, who did have to leave us today, will be very happy to provide some answers, because there were a few of the questions that have come through for her specifically. But I want to thank everybody very much for their participation. Thank you, Dr. Smith and Dr. Power, for providing us with such an in-depth look at your research. And thank you for doing this kind of research on behalf of the people we love and the people we care for in our carer community. And now it's up to me to hand back to Carol to conclude this session, to prepare everybody for the very next one. Thank you.
Thank you, Karen, and thank you to our presenters for a really illuminating and excellent session. Something that, as we've said, one of the aims of this project is to bring carers' experience and research together. And it's really exciting to see how that happens, not just through these sessions, but co-design and really engaging people throughout the research process and thinking from the beginning about what does it mean from a carer perspective? How can we make changes? Where are the things that we should focus upon to improve the quality of life for people being cared for and for carers? So thank you for a really interesting discussion this afternoon. One of the things we've really tried to focus on is barriers, and we heard a lot about barriers today, barriers of culture, barriers of language, barriers of expectation. But we've also heard some really excellent examples about how people are overcoming that, and how some of the, I guess, the way in which we've got to be clear about service expectations and how we want to bring service providers and service delivery with us on a change journey by showing them the benefits of better understanding the needs of people who are caring as well as the people who are being cared for. So thank you very much again for your participation in the panel, and for those of you who have forwarded questions, some of which have been answered and others of which we'll be following up later. It's really helped make it a very excellent session for us.